Hello, my name is Professor Becky Malby, and I'm here to talk to you about how do you do systems change? And it's around the topic of universal healthcare. How do we ensure the NHS is fair for all? So I lead a network of clinicians and third sector folk and community activists really concerned about how some people get more than others in terms of access or services in our NHS, and what can we do about it? And I'm going to share with you not a huge amount around the background of that, but the process we used to get to better solutions together. So let me share my screen with you. Here we go. And I'll pop myself in the corner here. Put you on full screen. Okay. So the propositions you'll see on our website, if you look at LSBU and then you look at universal healthcare, you'll see these three propositions, which are that with the best intentions in the world, the NHS is actually creating and contributing to health inequalities, partly by medicalising poverty, providing sticking plaster solutions with the best intentions that can make the problem of poverty invisible. Secondly, about not that services aren't accessible to all. In the vaccine programme, we managed to vaccinate people who are homeless or ethnic minority communities, and we know that those folks have had less access to healthcare. We know it's been a struggle to provide for them. We know they get less health checks. Why is that, and what can we do about it? Because when we really wanted to vaccinate them, we went and found them and did it. And the last thing is our patterns of funding, our historical patterns of funding, we think are creating a disadvantage to some members of our community. There is less funding going, for instance, to children and young people than there is to people who are elderly. Is that fair and is that right? And do we need to challenge it? So we've got some propositions here. And what we knew was that we just had to start doing the work together. The most important thing was to bring diverse people together from a range of backgrounds and see if what we could work out in terms of what we could do together. And the challenge of this is it's very, very different from the way the NHS tends to do transformation projects, which tends to be committee meetings and Gantt charts. And what we say here is we're going on this road of discovery. We need to involve a lot of people. There'll be new ideas and new solutions. And we have to be adaptable and open to work with those as they emerge. And that's a fundamental change of attitude. And it comes from these ideas. But we have this increasing volatility and uncertainty in our world. And we keep trying to slap certainty on top of it. And we just can't. We have to work with that sort of uncertainty. And there's some key principles in leading health systems that are fundamental and were underpinned every part of the way we worked here. Clear purpose. Our purpose was to ensure that healthcare was fair for all in our experimental labs, which were in Sussex, West Yorkshire, and within there, Hastings and Bradford. How do we make sure everybody has a fair chance? And then secondly, how do we create an identity around this where we all care? Third sector, NHS, local people. So if we belong together, we're more likely to try and find solutions together and collaborate. That's the second one. The third thing, we've really got to question our underlying assumptions, the way we see things, just get deeply underneath those and not take things as read or assumed or known. Third thing is don't jump in to fix things, live with some of the complexity and the mess, because it might be that the short-term fixes create long-term pain. Fourth thing is just bring more people into the conversation and to the solution finding. If you always work with the same people, you always get the same sorts of solutions. You just cannot see the other options. And that actually usually means bringing in local people. Give the chance for you to get some feedback so that you can try some stuff and see if it works. Do it in a peer-based way so everybody has an equal voice, everybody makes a contribution, and pay attention to the things that are working. I work in lots of systems where every time something's going on that's good, everyone sees it as an outline and says, oh, I can't do it like that because they've got a Tom or a Fatima who's leading it and they're marvelous people and we don't have a Tom or a Fatima, so we can't do it. Rather, what is going on in that place, in that GP practice, in that team? What's really happening there? What can we learn from it and what could we do? And we tend to assume that we cannot do things rather than we can do things. So really focus on what's working and do more of it, because across the NHS, there are fabulous examples of things working, but we don't connect them, don't make the most of them, and we don't add them up. Okay, relationship is the most important thing in the system. If you look at this picture of one of the workshops, you'll see Everybody's really intently, this is not a setup, this was just a picture taken as they were talking. The lady with the hat on was saying something and everybody thought it was so important. They were properly listening, properly focused on her. And that was really important. And in that picture, we've got NHS commissioning managers, we've got integrated care board managers, we've got community leaders, we've got members of the community, we've got people from the third sector. And you wouldn't know, would you, if you looked at that, who's who? It might be quite hard to tell. That's exactly the sort of relationship we're trying to generate in order to find the solutions together. So how do systems work? Here's the lovely Kim from Darcy 9, so 2014 with a 5-year forward view, showing me a picture here of all the complex things that are emerging in the NHS, from young people's mental health to elderly to obesity. Very complex problems. We aren't going to solve them with quick sticking plaster solutions or project plans. It's going to be really difficult because we're trying to do this work in the right hand box. We're pretty good at the mechanistic stuff, making sure if somebody goes to surgery, they have the operation on the right leg or the right arm or right bit of them anyway. We're good at that stuff. Deterministic world where we know if we do X, Y should always happen, but it has to be predictable. We're pretty good at the pathway stuff where we think we should do things better and we're getting advice and feedback from patients about it so we can improve our bit. The thing that we're struggling on here, we found harder to do, is co-production, where we are in a relational world where we are totally interdependent and we have to find better things to do, not the same old, same old. And that's where this work sits. Here are 10 properties of wicked problems, that is complex problems, the waterbed world, as Martin Fisher, my colleague, would say, which if you press down here, things pop up over here. In this waterbed world of wicked problems, sometimes we aren't sure whether we found the right solution either. But one thing's for sure, there will always be intended and unintended consequences. And we would expect, you don't have to go one, you have to just keep on trying until you find this thing that sticks. So it's more of an experimental laboratory type process than it is a known that you put in place because you know it's going to work. Now, this comes from my other very good colleague, Myron Rogers. And he taught me that we had to be really clear what question we were going to ask as we go into any systems work. And the question here was, how can we make sure the NHS is fair for all in Bradford and Hastings? And then we have to decide the system for that question. And we have to help the people who work here, who make up that system, know each other. When it says, does the system have access to itself? It means, do people know each other? Know what resources they've got? Do they know what else they could do together? And then what do they want to do? What can they do? Because the core principle is the knowledge is in the system. And actually, if you bring the diversity of people working that system together, they will generate solutions they care about and that stick. And we were trying to intervene in this work at the structural level, at the causals and generators, rather than sticking plaster, the events, the symptoms, patterns and generators. We were trying to find out what's going on. What is the pattern that's happening here? Maybe some communities get less, some communities get more. And why is that? What are the underlying principles or ways of operating that mean that inevitably keeps happening? And that's a really hard conversation to have because everybody thinks I'm a really nice person. I don't want to make it worse for anybody. So it's not intended. And we have to remember when we do this work, this is not a judgment about anybody's personality or commitment. It's a product of how the system works. And that's what we're trying to find. So one of the things that affects how a system works is how you see things, your assumptions about what's going on here. So you can use the language of hard to reach or the language of easy to ignore. Can you see how that changes your assumption about somebody? If they're hard to reach, that means they've sort of chosen to make it difficult for you to get to them. If they're easy to ignore, you've chosen to ignore them. That's quite a different model, isn't it? The way we see the problem determines how we act. The way we see the healthcare and the issues going on determine how we act. So our mental health crisis for young children in this country post the pandemic, we aren't treating as a crisis. We're treating it as something that we're going to just try and do something about. But we're not in crisis mode. We're not all guns blazing, trying whatever we can to solve that problem. Now, I would say it's a crisis. I see it as a crisis, but colleagues don't. So you can see how you see it. It's another thing, another chronic condition, maybe happening before the pandemic. We just have to try and find new ways of organising around, which take time. Is completely different from a crisis response, isn't it? You see how that works? Okay. The national assumption about who needs multidisciplinary teams tends to be around chronic complex disease and elderly people. And so a lot of our new multidisciplinary teams are pointing at those folks that actually our work in this program demonstrated there's lots of people that need multidisciplinary teams, but they're not all old and they're not all have chronic disease. And in fact, they're missing out. So let's have a look a bit more about this process of understanding what goes on. Because on the whole, our system tends to like this linear cause and effect model. It likes predictability, but it leads to some solutions that are too simple. And here's a little example of increased number of people waiting A&E. This was before the pandemic, this work. So the solutions at that time were to increase GP appointments, they still are, because the assumption were not enough primary care appointments for people going to A&E. And what that led to was increased demand in primary care. You open up more appointments, more people turn up because you're not meeting need. You're just offering appointments. And what was the problem? Well, let's have a look. The problems, it might be something quite different about what's going on in A&E. It could be about complexity. And therefore, if it was about complexity or chronic disease management rather than trauma, you might change who you put on the front door. You might change your skill mix. You might manage things differently. And if we look at this study, again, pre-pandemic, they found A&E breaches were actually all about increased complexity, older people, particularly on complex comorbidities, workforce-related increased lengths of stay. The juniors find it difficult to move people on because they were struggling with decision-making. Staffing and facilities out of pace with the changes, i.e. the sorts of people, the sort of workload didn't fit the space that people have. There was much more case management and diagnostics going on in A&E than there used to be, people waiting longer, etc. So it wasn't really, as a dominant narrative suggests at that time, increased numbers of poor primary care. But if you view it as the problem is that people can't be seen in primary care, so they come into A&E, you put in the wrong solution. This is exactly the domain of thinking that we were getting in with this piece of work, which is try and understand what's really happening around here. And we took this theory U process from Otto Scharmer, understand what's going on, observe the system, find what people have got energy for, try things out and help them stick. So this is the practice. This is the Universal Healthcare Labs. We started off with data mining, what's going on around here. We co-created solutions with diverse people. We tested some stuff and we're moving to adoption now. And here's some of this underlying assumptions, data mining we did. So we used data and visualizations to show what was happening. So here we are, this is who turns up in general practice and what sorts of people. And the top is the population, the second is the amount of GP time. And you can see the top box around the age of sort of 7 to 24. There's a lot of young people. And you can see they have very, very low access. Either they have no need, they're fit and well, or we aren't designing services to meet that need. And most of our colleagues, when we looked at this data, said, we don't believe they don't have need because our experience is this huge mental health need, particularly from the people who joined our workshops from schools. So we used data mining to do a number of assumptions and we found a number of things. And it's really worth checking. If we think the propositions we want it to be fair for all, we have to say, is it fair for all? And what we saw, here's average appointments per person by PCN across the groups of practice. And you can see the higher deprivation there were, the less appointments there were. And that isn't because they were rubbish GPs, it's because they had less staff. It was harder to recruit and retain staff. Locum costs were higher, etc., etc. So there was, and also the other thing that we found within our higher deprivation practices, people working in practices, working in poorer communities, the car health funding formula is not fair. It predicates an older population. These tend to be younger populations. So the pound per head was less in those practices. So they had less money to spend. I mean, that's absolutely, did you know that? I mean, I think that's just shocking that actually it isn't fair. So the second thing we found, which I think you might find useful and interesting, is the flat offer is unequal. So if you say we're going to open our, we're going to offer more appointments and we're going to offer them between 4 and 6 p.m. and we're going to offer them to everybody, what happens is the people who are used to getting appointments get more appointments. The people who are struggling to access appointments still don't get the appointments. So fair is not fair. And that's a fundamental principle when you're thinking about design of services, that you have to design differentially around need, not assume you just put one thing in and it works for everybody, because it makes things more unequal. And the way we went about this work is we set up a small design team in Bradford and in Hastings, the two experimental lab places. We brought together 6 to 8 people from the ICS who had different voices, different perspectives, somebody from the third sector, somebody who led community groups, somebody from commissioning, somebody who's a manager, somebody who was a clinicians, GPs, there are quite a few GPs. And we asked them to come in and to help us design the whole work. And we wanted them to come with their address book. Wanted them to come knowing that they could invite, their job was to invite people into this whole process, into the workshops. I wanted them to be curious about how you do this work and be willing to facilitate new approaches. This small group spent some time getting to know each other, working out the question, that underlying, what's the question of the system? What does universal healthcare mean? What do we think is going on? And then we ended up trying to work out, if that's the question, what's the system for that question? And they mapped out, if that's the question, what sort of percentage of police people are involved in that? What percentage of A&E staff are involved in that question? What percentage of community leaders? And we started to map it out on the basis that primarily in the workshops, where possible, we wanted half of the people taking part to be patients and carers or people from the community, and we wanted half to be from within the services. And so this design group not only worked out the question, they worked out the system for the question, and then they worked out the invitational process, entirely relational, big spreadsheets, and then they each invited sections of these communities, people they knew or people they could approach in a personal way, just not just random emails, but a personalized approach to recruitment, so that we could bring a diverse group of people into the room to discuss these issues. The workshop design really took these phases. The first workshop was observe, and the observe workshop used that data that we generated. I showed you some of those cards we made, but making things fun, we produced playing cards, a whole series of these data insights into what's really going around here, put them on the table and said, what do you notice? What strikes you? What do you feel passionate about? What are you shocked by? And really got people engaged with that, trying to work out what's going on, trying to understand what was happening in the system. Did it resonate with their experience? Of course it did. And nobody was judgmental or horrified about how the NHS was working. Everybody understood it. And then we asked them, say, well, who in this workshop don't you know? Which part of the system don't you understand? And we asked them to go on visits, to go visit each part of the system they might not know. Lovely story from Hastings. Some of the elderly ladies there went to visit a GP practice because they said, we can't get appointments to GP practice, and they're hopeless. They just don't, they can't organize themselves. And they went on the visit, and they went behind the front desk, and they spent the day in the practice, deeply in how the practice works. And they came out going, we can't believe how busy they are. They're so fantastic. They're marvelous people. They work so hard. We have to really tell the community that they just got to be really careful how they use this resource, because it's so important. And they're working so hard and they're so stretched. A phenomenal change of attitude based on those visits. So the workshops and the visits help people begin to lose some of their prejudices and assumptions about what's going on. Workshop 2, we retreated. We sort of tried to find out what we cared about. We interviewed each other. We told stories. We found out what it was that mattered to us. We worked out what we were committed to, what we were passionate about, what we were incensed about. And we coalesced in all sorts of groups around those issues. And we chose in the workshop 3, said, which of these do we want to take action over? And we set up teams to take action, to have a go, to experiment with different things. The underpinning maxims to this, Myron's maxims, I talked to you about him earlier, these, that people own what they create. So it has to be, people have to be involved in both understanding the problem and finding the solution and generating put that solution in place. It has to be about real work, things that people care about. That people who do the work do the change. You can't tell somebody else over here can't do the change for you. You have to do it. If we've got issues going on in general practice, then general practice has to solve that. Somebody else can't do it and then give it to general practice and say, implement this, it will never work. You have to know the system. You have to start, and Mara says start anywhere, follow it everywhere. You sort of have to start. I think I put that at the beginning. Get going with a prototype, with something where you can create an experiment with a small group of people and see where it goes. The process we use to get to the future is the future we get. So how we do this, all that I've been explaining about the workshops, the invitational process, the conversational process, the diversity of the group, that is the future. You're generating the relationships that are going to be long-standing. The story of Hastings, the 120 people who turned up at every single workshop, and then the celebration event last week, phenomenal. They will not forget each other. They will not forget the experience. They will not forget the funny things that happened in workshops, the kids running up and down on the prom. They won't forget how hard it was to listen to the Chinese community because they just didn't know if we really wanted to. No, there were some difficult things we did and some amazing things. And they'll remember the cake and the tea and the chaos and the love. And all of that, because all of those people will stay working in Hastings and living in Hastings, means that that 120 people can continue to do something really amazing together. Okay. So here's some examples. We started in those workshops, what we hope for. What do we want to do together? Round and round and round, understand each other's ambition. We did that amplifying what makes things work. What's going on? We're great in Hastings and Bradford now. What have we learned when we've done that well? So we persistently built it in to people's own experience and tacit knowledge, as well as that data that turned up the heat around those assumptions. And then we found some things to prototype. And the prototype process is this, which is you have to try stuff out before you adopt it. And you want to try it in a little experimental space. It might be a street, it might be this population, it might be a practice. If you prototype small, but you're always thinking big, you're sort of de-risking your ideas, and it's absolutely an experiment. And you have to go into it with this humble mindset. You have to learn, you have to iterate. So these prototype groups, the things they wanted to try came out of those workshops. Mixed groups of people trying stuff out together over a course of about 6 weeks, saying, what can we do differently together that we couldn't do on our own? And you're not trying to build the ultimate solution. You're just trying to build something that works. Well, each of these prototypes had a mentor or a sponsor, and their job was to give permission and to encourage and to provide headroom. And certainly wasn't to judge or demand any evaluation. We asked them to fill in some pro formas so that they could at least see or clarify what it is they wanted to do, the issue, the assumptions they held, the population community's viewpoint, the data and what it told them, what else do they need to find out, who else they need to involve, and what do they need to try and test out. And we tested in those 1, 2, 3, 4 cycles. So the testing was not to provide a finished model, it's to provide a new model, new insights. It's a double loop learning. So you're modest about how big a caseload or a scale you're going to work on, but you're really, really committed to learning. These were some of the prototypes that we tried, designing children and young people friendly practices, reaching out to people who have drug and alcohol dependency into the community, not learning lessons from the vaccine, i.e. going out to see them, a very small group, working out, do we need to provide it in the voluntary sector, or is it that we need to develop trust in order to transition these people back into mainstream NHS services? Can we do that? Could we ensure that our marginalized communities could actually be mainstream? What would that look like? Really interesting prototype. Trying to take people off the hands of general practice at medicalizing poverty. Look at that list down there. All the things the service in Hastings said, we could help those people. Let's come in and find them. We can help them find out what's available in the third sector. We can sort out their housing and their fuel poverty. We can help them be active, etc. So lots and lots of different prototypes were going on. And this was just the Hastings group. And then they brought those prototypes, experimented and tried stuff out and got stuck on, got worried. And they brought them to a panel within each of the system. And their job wasn't to say yes or no to these prototypes, but was to check and challenge and say, how's it going? What's worked? What could we learn? What might we do differently? And we use the Lennox sustainability questions for the check and challenge team. So these are the sponsors. So we found these questions were really helpful for our check and challenge process for our sponsors and mentors to really work with the prototypes to understand what sticks, what have they learned, not just whether the actual thing worked, but what have they learned about doing that work? What do they recommend in terms of spread, in terms of scale, in terms of what next? So our process overall is check what's really going on in the system using data, expand what you see, how you see the issues, and do that by diversifying who's involved in really great relational conversations. Change your thinking, how you see the issue, and that gives you more options for what you can do together. And then test, prototype, and share the learning from that. So just a reminder that as we get into this type of process, that it's really important to be in proper listening conversations, that we're not into that downloading, just waiting for a gap to say something. We're properly in service to the work. We're really interested in what other people have got to say. And then just a bit of a heads up on spread. It's really an organic process with some steps that we really need support at system level. You've got to really always align your incentive system with where you're going with spread. It mustn't be about relying on teams to embrace the model. We've got to be very active about helping it happen. So making sure we've got a system leader that's engaged throughout the whole process, willing to champion, embed it, bring it into the way we do business around here. So within our prototypes, we've had some really great stuff on primary care and integrated care teams. And that's going into the model of design of the new integrated care teams, full of board delivery model, lessons learned from this, relationships built, and some really good data to support them. So it's been really helpful for spread. In order to generate any sort of spread, people have to be frustrated with the status quo. We found using the data packs has been really helpful with that. And then make sure that you, I guess, seed power in order to help teams do the right thing. So a few things on lessons on the process. You just need the community as partners throughout this process. They're very, very tolerant. They're very, very supportive of the NHS. They're very keen to participate. They will give time, and they'll give phenomenal asset and help. So we need to ask for help. We asked for help in the pandemic and the vaccine, and people stepped up. We need to ask for help with all this type of work that we're doing now. System leadership is pretty key. People in the middle really struggle to have the authority. They don't feel confident in leading change, so they need their system leaders. And we have to be non-judgmental and honest about our relationship, check our assumptions and welcome people to the work. And I'm going to just remind you of another of my friend Myron's maxims, which is the old world bites back. What to watch out for is this notion of culture eats strategy for breakfast. So just remember, culture is really embedded in the NHS. People will revert back to things they know and love. And we just have to hold that space and enable people to experiment and try. I hope that was a helpful way of trying to describe this sort of 10-month process we've been on in Hastings and Bradford, West Yorkshire and Sussex. Gives you a flavour of it. And within the materials associated with this, there are an awful lot of resources. There are some easy reads, some good articles, and there are some references. So I hope you found that helpful. And of course, you can always email us at healthlab@lsbu.ac.uk or r.malby@lsbu.ac.uk. Thank you.